We discussed the transition lead problem last video, and the solution we found was two contiguous leads to diagnose occlusion. And you already need to understand this idea of contiguity to understand the STEMI criteria. But what do we mean by contiguity? Contiguous means from the same territory. Two contiguous leads are from the same part of the heart. When we say part of the heart, we mean a territory of the heart. Territory basically means a part of the heart supplied by the same artery. Which blood vessel supplies which territory is usually a certain vessel, with some variation. Reciprocals happen when opposite territories mirror the injured territory. Big picture is that there are three territories and three vessels. The inferior territory is leads 2, 3, and AVF. The vessel is usually the right coronary artery. The anterior distribution or territory is V1 through V4. The vessel is usually the left anterior descending artery. The lateral distribution or territory is 1, AVL, V5, and V6. This vessel is usually the left circumflex artery. Biggest shortcut I can give for identifying reciprocals in general is if there are multiple depressed leads in a territory, look for markers of occlusion in another territory. Each territory, as we've noted, basically corresponds to a vessel, but each vessel also has a major branch, and individual anatomy differs. For this reason, we really need to think about more than three territories. Here's an excerpt from the ECG sheet showing all the territories on the 12 lead that we'll be discussing. The basic territories we've already discussed: inferior in purple, lateral in green, and anterior in tan. So let's take a closer look at the territories now. There are 6 patterns or territories indicating coronary occlusion. In the limb leads, reciprocals are more likely. In the precordial leads, reciprocals are less likely. There's also one pattern indicating demand ischemia that we will discuss. There are 2 sets of leads, the limb leads and the precordial leads, and we'll talk about the limb leads first. We basically see the entire left ventricle with the limb leads. The span from AVL to lead 3 is 150 degrees technically, but I think it's practically more like 180. The opposition of these leads, AVL and lead 3, to each other makes them common and important mutual reciprocals. Let's start with the high lateral leads. Leads 1 and AVL. These are commonly associated with reciprocals in the inferior leads, especially lead 3, which is 150 degrees opposed to AVL. The supply is either the LAD or the left circumflex. In occlusion of the proximal LAD, or of the first diagonal branch of the LAD, AVL and V2 are often elevated with a reciprocal in lead 3, the so-called South African flag sign. Now don't panic, but in these cases, lead 1 is often benign appearing. For this reason, AVL and V2 should be considered contiguous leads. The supply in this situation is the LAD or the first diagonal. Here's a spot on your sheet reminding us of this point. The inferior leads, as we've discussed, are 2, 3, and AVF. Reciprocals are very commonly associated with injury in this area. In fact, the AVL reciprocal often precedes injury changes in 2, 3, and AVF. The supply is usually the right coronary artery, sometimes the circumflex, sometimes a wraparound left anterior descending artery. STE in 3 greater than 2 and STD in AVL more than lead 1 suggests a right coronary artery occlusion. This is more likely to be associated with a right ventricular infarct, which is preload dependent, which is why we don't give nitro to suspected RCA occlusion. Note that on the ECG sheet, we have a reminder that inferior MI, we often see the AVL reciprocal before inferior STE. Again, since AVL and lead 3 are about 150 degrees opposed, we often have this strong reciprocal relationship between AVL and lead 3. Let's expand on inferior MI and RV infarct. RV infarct is suggested by, as we've already discussed, STE in lead 3 greater than 2 and ST depression in AVL greater than lead 1. Now don't panic, but it's also supported by V4R elevation, which is when you take a lead and put it on the right side of the chest, about where V4 would be if we were placing all the precordial leads on the right side, and STE in V1 and an isoelectric or depressed V2. These are advanced points. Junior learners, don't get hung up on this. Again, the clinical significance is that right ventricular MI is preload dependent, so no nitro, give IV fluids if the patient is hypotensive. Let's expand some on why you can see ST elevation in V1 and an isoelectric or depressed V2 in right ventricular infarct. This is a straight ahead view of the heart with the right ventricle transparent and the LV in color. You can see that the lead 1 overlies the RV here, which is why it can be elevated. You can see that the V1 label is overlying a branch of the RCA here. V2 technically overlies the RV as well, but it picks up much more of the border between the left ventricle and the right ventricle, the septum, than the right ventricle. To be clear, we've now discussed the one circumstance that determining the vessel is clinically particularly relevant to us, and that's when it might indicate right ventricular MI. In other circumstances, it's less essential for you to be able to specify which vessel or branch is occluded. It's more important for you to identify contiguous markers of injury and identify any associated reciprocals. Precordial leads, unlike the limb leads, only give us about a 90-degree view of the left ventricle. For this reason, reciprocals are less common. The back of the left ventricle is not covered by ECG leads. However, if they were, V1 through V4 would be directly opposite these leads. We will discuss the implications of this. First, let's discuss the septal leads V1 through V2. There are actually reciprocals a fair amount of the time with injury in this territory. Smith calls V5 or V6 depression with elevation in V1 through V2 precordial swirl. Sometimes we'll also see reciprocals in the limb leads. The supply is usually the proximal LAD, but as we've discussed, STE in V1 greater than V2 could be right coronary artery occlusion. You can see the different colors corresponding to the different vessels on the picture of the heart on the right. Now the anterior leads, which are leads V2 through V4. This distribution is notable for the rarity of reciprocals because there are no opposing leads here. Sometimes you will see reciprocals in the limb leads. The supply is pretty reliably the mid left anterior descending artery. Now let's discuss the lateral precordial leads, leads V5 and V6. Sometimes there are reciprocals in the septal leads, sometimes in the limb leads. The supply is usually the circumflex or its branch, the obtuse marginal artery. Less often it's the LAD or its main branch, the D1. Now the time has come to talk about the back of the heart. So there aren't any leads on the back of the heart. So we have to rely on identifying V1 through V4 reciprocals as evidence of occlusion. Sometimes there's associated elevation, oftentimes in the inferior leads, less often in the high lateral leads. The supply is the right coronary artery versus the circumflex artery. You can see the right coronary artery in its big branch, the PDA, on the right in blue, and then you can see a branch of the circumflex on the left in yellow highlighting. Dominance, for your information, refers to which vessel the posterior descending artery, labeled on the right, branches from. If it's right dominant, then the PDA descends from the right coronary artery, like here. If it's left dominant, it branches from the circumflex. Now some advanced points on posterior MI diagnosis. You may be asked to obtain posterior leads if you're concerned about posterior MI, and the ACC kind of has it both ways with this, noting that depression in V1 through V3 is concerning, but noting that the finding is confirmed by 0.5 millimeter of elevation in these posterior leads under the left scapula, as shown in this picture. We don't have posterior leads on the ECG for a reason in general. All the distance and error between the back of the heart and the electrodes makes these tracings difficult to interpret. And Smith and Myers have demonstrated that ST depression max V1 through V4 is very specific for coronary occlusion. So if you feel strongly that this person has a concerning presentation and they have ST depression maximum in V1 through V4, stick to your guns regardless of what the posterior leads show. Now it's time for the light gray background and a digression. Hypertrophy can have depressions and distributions that, based on what we've talked about, can be concerning for reciprocals. So it's time for us to take a side quest back to lecture 1, identifying occlusion on a single ECG, and play A versus B again. Which one of these, A or B, is more concerning for being a reciprocal? So I have shown you two images here, but only one of them is from an actual ECG. That one is image A. Image B is an inverted image of the same tracing B that I used to demonstrate reassuring T-wave contour in our last video. Let's look at two images that are on your ECG sheet to further demonstrate the mirror principle, which expresses the tendency for reassuring depressed contours to look like mirror images of reassuring elevated contours, and vice versa. Now for something different. I'm now going to identify a distribution or territory for demand ischemia rather than acute coronary occlusion. That is supply-demand mismatch. We'll be looking for J-point depression rather than J-point elevation in this distribution. Leads to V5 and V6 as the demand watershed, where in a supply-demand mismatch situation, we see maximum ST depression. We will often see reciprocal elevation in AVR. You can see sort of here that the supply in this area is an area served by the dregs of all of the vessels. Maximum depression in these leads signifies demand ischemia. Let's take a moment at this time to talk about AVR, or as I like to call it, the great reciprocal. It does not have contiguous leads, and unlike the other leads, it does not point to the left ventricle, so to speak, rather directly at the right atrium. It is elevated when other leads are depressed, especially lead 2, its opposite. With ST depression max 2, V5, and V6, elevation in AVR can indicate shock, including cardiogenic shock secondary to a ruptured left main plaque. So it is very important to identify patients that are having demand ischemia, and they can be very sick. But AVR elevation is not necessarily a marker of complete occlusion like contiguous elevation in other territories. Having gone into all this detail, let's zoom back out to the big picture. There are 3 territories and 3 vessels. The inferior is usually associated with the RCA. The anterior is usually associated with the LAD. The lateral is usually associated with the circumflex. Recall again the reciprocal's big picture. Occlusion markers in one territory, and then reciprocal depressions in another territory. That said, I've included the PAILS mnemonic on your ECG sheet, and I'm mentioning it here because it can help learners remember the most common reciprocal relationships between different territories. However, these rules are often broken and the strength of the relationship varies. The inferior and high lateral relationship is much stronger than the anterior and inferior relationship, for example. And sometimes, as we discussed, high lateral and septal leads can both be concerning for occlusion. Conclusion, in general, when you see multiple depressions, I'd frame the issue as, am I looking at a supply-demand mismatch, or am I looking at reciprocals to occlusion markers? Again, supply-demand mismatch in a patient with a ruptured left main plaque and lots of collaterals warrants a cath, but it's perhaps a more nuanced situation, if an equally perilous one, compared to someone with a totally occluded coronary artery without collaterals that needs it open stat. Keep in mind that the demand pattern is associated with shock, and these patients are sick and have high mortality. Remember the mirror principle when thinking about depression contour. It can help us distinguish contiguous depressions concerning for occlusion from baseline hypertrophy variants. And in parting, remember that coronary occlusion is a clinical diagnosis. When in doubt, you can get serial ECGs and look for changes. Clinical context is king, and as some interventional cardiologists like to say, the die don't lie.